Our last speaker for this morning will be Dr. Madhu Reddy. Dr. Reddy is the newest member of our practice and the faculty at the University of Kansas Hospital. And we welcome him to our group. He just finished his electrophysiology training with us. He will talk to us on understanding lead and cardiac device failure and appropriate management strategies. Madhu.
Thank you, Dr. Vazek. And thank you, everyone, for being here today. I got a bad deal. I'm speaking just before lunch, and I'm talking about bad stuff. So I'll try to make it quick, and I don't have any disclosures. I'll start off with a quote. If you're not failing every now and again, it's a sign you're not doing anything very innovative. That essentially summarizes not exactly in clinical care, but innovation. We know our device implantations have dramatically increased over the last 1 decade and kind of plateaued off over the last 5 years. And if you see, the complexity of the devices are also increasing. We have more ICDs implanted, and the pacemaker use has been plateaued off. Dual chamber pacemaker implantation has increased. So overall, the complexity of the devices has been increasing over time. Now, I want to just go over the terms which we come across: advisory, safety alert, and recall. They all mean the same, essentially. It's being used in different forms, and recall is the common term used by the industry, in other industries like a car, auto manufacturer, where when there is a recall, you essentially replace the part or the device. But that doesn't hold the same for EP, where if it's a recall, it's an advisory, and you still have to do a lot of processing whether that device needs to be exchanged or not. So we keep mixing this advisory, safety alert, and recall. HRS suggests using the term advisory or safety alert instead of recall, and I think the industry follows the same. So when you go back to look at the classification of the devices, there is opposite designations of the complexity of the device as far as healthcare risk is concerned, and the recall classification. The most complex device, like the ICDs and pacemakers, are device classification 3, whereas the worst of the recalls is recall classification 1. So sometimes these terms may be confusing. So if you see all statistics regarding medical devices, if you see the picture on the left, you have the class 1 recalls are a very small fraction. Most of the recalls are class 2 and class 3. And this is all medical devices, not necessarily cardiovascular devices. If you come to the next table on the right side, the cardiovascular devices, they contribute to about 15% of all the recalls. However, class 1 recalls, it's a predominant fraction. It's probably the highest fraction of class 1 recalls. So we're dealing with more complex devices with high impact. So what has been the trend of malfunction? If you look at the pacemaker malfunction rate, obviously, initial years of evolution of the technology, there has been a higher incidence of malfunction, but the technology kind of matured, and over the last decade, it has essentially stayed stable, less than 1%, which is considered a reasonably good number. Whereas the ICD malfunction rate, which includes generators and the leads, there has been a biphasic or bimodal distribution of the incidence. If you see, it decreased significantly earlier from the 80s to the 90s. However, at the beginning of the new millennium, it has increased. This is 2002, and even 2005 and 2009. Again, there has been an increase in the malfunction rates. If you go by classifying the malfunctions, I know there are hardware malfunctions and firmware abnormalities. Most of them are hardware. This is lead design, this is generator designs. The firmware abnormalities are easier to fix, and they're not as common. How do we understand this incidence of failures? This is something which we need to always keep in mind, because whenever someone's giving you numbers, you have to see where the numbers are coming from. There are different types of analyses in identifying the incidence of failure. There are return product analysis, which is probably which is the highest number in the denominator, but it's based on the products which are returned to the industry and analyzed. The good thing about that is you can actually analyze in detail about the products which have been returned. The bad thing is that very few products are actually returned. That has changed over time. Now more and more products are being returned, so that thing is improving, but that underestimates the real incidence of failure. Complaints, this is clinician complaints, and this is helpful if it's a rare incidence, if it's a rare thing, and there are 3, 4 happening across the globe, and if there is a complaint that can help us, but overall doesn't contribute much in identifying the incidents. Post-approval clinical studies are probably the best, but they're very expensive. These days, FDA has mandated many new devices to undergo approval studies. Some are FDA mandated, some are industry mandated, but you do have these things increasing. Registries have their observational limitations. Passive reporting systems, so this is a free press. You can go ahead and put what you want, but the authenticity of the device reporting is not very accurate, even though till now we've made reasonable advances in identifying some early failures and using the MOD database. So there are pacemaker generators, pacemaker leads, ICD generators, ICD leads. So the pacemaker generator and leads are not as common today's in the last 10 years. ICD generators and ICD leads have had many issues. So in the interest of time, I won't go in details of all the recalls. I'll go over a couple, 3 common ones which we're encountering in today's world and go over the management of the same. So this is the list of all the ICD advisories. You probably have around 8 of them using different companies, and I don't know if you can read, but I can't. But this was early 2011, so this does not include the ones which have been reported after that, which is St. Jude's Riata, which was November of 2011. So we have the St. Jude's earlier generator. Then we have the Guidant in 2005, where we had a lot of recalls on the Prism and Contact generators, and of course Medtronic Fidelis lead. So these are the more common ones. The importance of these recalls obviously is dependent on what is the kind of a complication which can occur due to the malfunction, and what is the prevalence of that device in the population at this time. So the ICD leads have as is mentioned, exponentially increased. So anything which is related to a common ICD lead has a bigger impact than smaller generators. This is the average ICD survival. It's a little old, of 2008 data. So most of the ICD lead survivals are around 6 to 8 years. Median is around 6 years at that point of time. Now we have bigger registries, we have longer follow-up, and this is the actual real-life survival. Again, lead abrasion, I just want to touch base on that because this is one of the things which we're going to talk about. It's classified into different categories. You have external abrasion or internal abrasion, and external abrasion can be because of many reasons, and internal abrasion can be because of many reasons. So the mechanism of any abrasion is completely, a particular abrasion is completely different from the other. So we need to get into the details as to what exactly is happening. Is it inside out or outside in determining the mechanism of the failure, which will help us project as to what can happen to the current leads. So I'll start off with the Sprint Fidelis leads, which is a Medtronic lead. Was marketed in September 2004. Very popular lead. Was at that time the lead size was a pretty good marketing. It was very attractive. The smaller the lead, it was easier for the physician to implant. So it was one of the smallest leads at that point of time. And a lot of leads planted. April 2007, there was a confirmed recognition of increased failure rate. And October, it was voluntarily withdrawn from the market. About 268,000 implants all over the world, with about 196,000 in the US. Early 2011, there were still 160,000 leads still implanted in patients. At this point of time, that number is significantly less. So this is the overall design. I won't go into the details, but you see it's not a coaxial lead, which is the change in the pattern of lead design over the last decade. Earlier leads were coaxial, and now they're not coaxial. You have multiple lumens with the pace sense and the conductor coils running parallel to each other, and each of these I'm sorry, I'm not able to get a pointer, but I want to show you that you can see that the lumen which goes to the distal, which is the pace, which is the spiral at 6 o'clock position, and the pace sense conductor cables is on the top, and the defib cables are on at 3 o'clock and 9 o'clock positions. The most common location of the fracture was the pace sense conductor, which is going to the ring, which is at the 12 o'clock position. So this is the same on a radiographic image. You see the redemonstration of those high voltage conductor cables and the proximal pace sense conductor, the 12 o'clock position one. So this was the early recognition. This was in late 2008, early 2009. It was already identified that the Fidelis fracture rate was much higher than the expected normal for the rest of the earlier leads. And the thing which kind of was concerning was that the rate at which it was fracturing was increasing. So there was an increasing rate over time. If you see, the rate at first year was lesser, and the second year was more, and the third year was higher. And obviously that was concerning as to what is going to happen, 8 years down the lane. And as I mentioned earlier, the comparisons have to be made by real life and product return analysis and actual studies. So if you can see, there's a significant difference in the projected survival of the leads. And this is as of May 2013. So this is the return lead analysis and the CareLink data. There is still increasing. It's not increasing, but there is a kind of plateaued effect or the same rate of failure of the Sprint Fidelis leads. How do they present? The earlier presentations, again, we'll talk about the management, but the earlier presentations, 50% of them were having inappropriate shocks. That is because of short VB intervals, because of the fracture of the pace, the proximal pace conductor. And some of them were picked up by routine follow-up. And there have been other studies which have been done since then till now, and these are the newer additions to understanding the Sprint Fidelis fracture. And what we know at this time is the exponential increase in the fracture is actually plateaued and become linear after 3 years. And there are other predictors, so again, retrospective studies or observational studies, and with whatever limitations. But younger people were having more fractures. Women had a higher fracture rate. People who had a better ejection fraction had a higher fracture rate. If it's a part of the CRT that had a higher fracture rate, if there was a known previous lead failure, those patients had a higher fracture rate. I didn't include, but people who underwent a generator change had a higher fracture rate independent of the age of the lead. So these are in line with the expected lead fractures in other leads. It's just that we don't have enough numbers to prove statistical significance, but the other leads also had a similar trend that younger people always have higher fracture rates. The other thing which was concerning was like the leads which were functionally normal also had subclinical fractures. This was from Brigham, Dr. Epstein's study, where they evaluated the leads. They kind of prophylactically extracted the leads even before they showed any clinical or electrical evidence of fracture. And these are the analyses of the lead under high frequency microscopes. And if you see the leads which were functionally normal did have some damage to the conductor cables, as you can see in figure A. And if you do special tests, you can see that there is also an electrical damage to that. The same is on the right side. So, we know that the leads have fractures, and we also know why, how they and what is the management strategies that have been proposed, and has there been any evolution in how we are approaching this sprint fidelis lead fractures. So first thing was lead LIA, the lead integrity algorithm, because we know that there were short VV intervals and there was a decrease in the R wave or the rise in impedance. So these were the three electrical signs of impending fracture or subclinical fracture. So a lead integrity algorithm just uses these features and then tries to pick up if it satisfies a particular criteria of 2 out of 3. It gives us an alert, and that way we can pick up a subclinical fracture ahead of time before a clinical event of inappropriate shock happens. And LIA has proven again and again about a 50% decrease in inappropriate shocks. Now, what do we do? Do we extract the leads, all of them? The initial experience has been not very good. This is from the Canadian experience. And they compared what happened to people in whom the leads were removed and in whom the leads were abandoned. This was earlier. The leads were younger too. So the incidence of complications was lower in leads which were abandoned, and the leads which were removed, those patients had more complications, probably, I mean, obviously related to the extraction process. There were actually 2 deaths in the extraction process too. So that kind of paved way to the recommendations at that point of time that what we do is routine follow-up, full interrogation, download the LIA, have remote monitoring, that's another key. Put them in the remote monitoring system, and if there is any sign of signs of fracture, then intervene. There was no recommendation of prophylactic extraction of the lead, even today. And there are other options. You know, you can assess the various patient characteristics and intervene accordingly. If it's a pace-sense fracture, the patient is 89, and maybe you can get away with another ICD lead or another pace-sense lead, and things like that. So, I mean, there are many options, but is that what we need to do, or is there a safety in the lead extraction? This is our own experience here, showing that as the lead ages, there is increasing complexity of the lead extraction, in the sense that they need more laser extractions. Probably after about 50 months or so, every lead needed a laser extraction. And this is also our experience we'll be presenting this November, where the green one is the Fidelis, and the blue are the other ICD leads, and the mustard color is the pacemaker, RV pacemaker leads. So Sprint Fidelis lead actually required more extraction support in the form of laser lead or mechanical support for extraction. So does this translate to increased complications? At least in our experience, we did not. We didn't have any. This was updated till April of 2013. We did not have any major complications with extractions of the Sprint Fidelis lead by that time. And that has been shown in other, this is Cleveland Clinic experience, a very large experience. They actually, in the recall leads, they had RIADA too, and the complication rate is not significantly different from the non-recall leads with major complications of 1.4%. So with this reasonable safety in experienced hands, one can make a case in specialized centers under extreme care after considering the patient comorbidities. It may be you can consider extracting the lead at the time of generator change, but again, all these things have to be taken into consideration. It cannot be everyone who has a Fidelis lead needs to be extracted. So that's about Fidelis. I don't have much time, so we'll just go through a quick with the rest of the leads. The RIATA, which is actually the increasing frequency of fractures, increasingly reported failures. And about 200,000 RIATAs and RIATA STIC leads were implanted, and they were recalled in November of 2011. The primary problem is externalization of the conductor cables. I'll show you. This is the X-ray. You can see. I don't know if you can see it from there, but conductor cables kind of extrude through the insulation, which is made of silicone, and it's on the right side, redemonstration of the same. There has been some change in the design from the silicone 8 French RIATA leads to the 7 French ST leads, where the lumen has decreased and all the conductor cables are pulled towards the center, adding stability to the lead. I could say it is because till now what we have seen is the ST leads, actually in the next slide, the ST leads have lesser externalization, even adjusting for the age of the lead. And these are the different studies reported till date. And there is about, some studies have lower rate because of the methodology, but on average between 20 to 30% externalization rate. Now, are there any predictors? Again, there is age and gender. It's no different from the other lead failures, ICD lead failures. Now, does mechanical failure mean electrical failure? Do they mean the same? Should the management be the same? It's difficult to answer. We know that if you look more, you'll find more. So the mechanical failures obviously most of the mechanical failures are inert. They did not have electrical failures. On the other hand, there are electrical failures, and about 30% of them had some mechanical issues. So both go hand in hand, but the overlap is very small, and probably the mechanisms are different. So we need to keep that in mind. And obviously, the sprint fidelis and the Riata are present in a different electrical failure pattern. Noise is more in Riata, and impedance change is more in fidelis because of the mechanism of failure. As I said, we are going through, if you look more, you'll find more. This is DFT testing in a patient with a Riata lead, and DFT didn't work because the circuit was damaged and the charge was aborted. So if you look more, you can find more, but still, even after looking, the incidence of electrical failure is not anywhere close to the mechanical failure rate. So most of the mechanical Riata leads still do not have electrical failures. So these are the current recommendations that have changed over time, but these are the latest recommendations that you should image Riata and Riata ST leads for patients to assess for externalization. Remote monitoring is strongly encouraged. No explantation of normally functioning leads with or without externalized conductors. This is the current recommendations. Again, everyone is adjusting to their practice. I'll go a couple sides on this quick side, quick flex. These are the LV leads. The impact is less. It's again silicone coating and externalization of the conductor cables through the silicone coating. This is our experience, we have about 50% some structural abnormality, complete externalization, about 30% of the leads. We did not find any electrical failures in all these leads. We also saw some subclinical externalization. This is a structurally normal LV lead. When we look at that under microscope, you see that the conductor cables were about to extrude out. So just like the fidelis, I think it's a spectrum. The mechanical failure is a spectrum. So there are other studies. There's one other study where we found some electrical failures in quick side, quick flex, but they did not impact the heart failure hospitalization. So no clinically significant impact at this point of time. So we need to assess the risk-benefit. Pacemaker dependence is one of the critical factors we need to plug in patients who have any kind of lead failure. Prior history of ventricular arrhythmias, primary prevention, secondary prevention, assessment of their life expectancy, impending battery depletion, and anxiety about lead failure. So patient-related factors are very important, as are the lead-related factors. So if you have a subset of high failure leads, then probably you need to be more aggressive. So all these things should be combined, and most of the HRS consensus document is being conservative till you find any major abnormalities. I think that's all I have. So my summary, device failures are almost unavoidable in today's EP due to the innovation. We try our best, but attempts are underway to minimize their incidence. The key is bridging the gap between identifying the failure and recalling the leads. ICD lead failures are most common, and one of the most devastating is the device malfunctions. In taking steps to recall the failed device, a thorough assessment of the risks and benefits of device replacement should be made with the patient. Thank you.